Hello everyone, myself Dr. Rajni Agarwal, Professor and Head Department of Periodontology and Oral Implantology, Surendra Dental College and Research Institute, Shri Ganganagar. Today, let's talk about dental calculus. What is dental calculus? It is a mineralized dental plaque which is covered by the unmineralized dental plaque. It is classified as supragingival calculus and the subgingival calculus, depending on whether it is above the gingival margin or it is below the gingival margin. What is supragingival calculus? It is located coronal to the gingival margin, white to yellow in color, hard with clay-like consistency and easily detachable from tooth surface. After removal, it may recur and it is mainly found on the lingual surfaces of the mandibular anterior teeth as well as on the buccal surface of maxillary molars because the duct of the glands they open near the lingual surface of mandibular anteriors and parotid duct it opens near the buccal surface of maxillary molars where the saliva it is more accumulated and more calcium and phosphate is more available that results in the supragingival calculus. It can be localized as well as it can be generalized. This is a picture which shows the dental calculus which is supragingival that is above the gingival margin. Subgingival calculus it is located below the crest of the gingival margin and is not visible routinely on clinical examination. It can be evaluated using the explorer which we feel that it is with the tactile perception. So subgingival calculus it is mainly hard and dense. It is dark brown to green black in color and is firmly attached. It is not easily detached whereas supragingival is easily detachable. It extends to the base of the pocket in the chronic periodontitis and do not reach the junction epithelium. On removal, reduction in gingival inflammation and probing depth within clinical attachment level is observed. This is a radiograph which shows the calculus or the tartar under the gums which is not seen because it is below the gingival margin. Now what do dental calculus contain? It contains mainly the mineralized component that is the calcium and phosphate and that is the compounds that is calcium phosphate, calcium carbonate and magnesium phosphate. It is two-thirds crystalline in structures, that is, it has crystals of hydroxyapatite, magnesium white-locklite, octacalcium phosphate, as well as brucite. Hydroxyapatite and octacalcium phosphate are the main important crystals which are present, whereas the others, such as brucite, is present in the mandibular anterior region. Magnesium white-locklite, it is present in the posterior region. Now, rest apart from 70 to 90% mineralized content, it contains 9 to 10% of organic content consisting of protein polysaccharide complexes, desquamated epithelial cells, leukocytes, and the number of microorganisms. And it is this protein polysaccharide complexes, they are formed from carbohydrates, salivary proteins, as well as the lipids. Subgingival calculus, it has the same hydroxyapatite content as that of the supragingival content, but magnesium white-locklite is more in subgingival. Supragingival contains more of the brucite and octacalcium phosphate. The ratio of calcium to phosphate is higher subgingivally and sodium content it increases to depth of the periodontal pockets. Salivary proteins, they are not found subgingivally. Now, how do this calculus attach to the tooth surface? By the organic pellicle on the enamel, by mechanical locking, by the surface irregularities, by the undersurface depressions and sloping mounds of unaltered cementum, by penetration of calculus bacteria into the cementum. How is it formed? First, the dental plaque layer is formed and within first to 14 day mineralization starts occur. And this mineral content is derived from the saliva for supragingival and gingival crevicular fluid for subgingival calculus. Early plaque, it contains more calcium and 3 times more phosphorus, whereas less potassium than that of the non-calculus formers. Now there are theories of mineralization of dental calculus. This mineralization of calculus occurs when there is increase in the degree of saturation of calcium and phosphate ions. When do that occur? When there is increase in the pH of saliva. Because why? Because of the formation of ammonia and loss of carbon dioxide from the dental plaque bacteria, which results in increase in pH, causing more of the precipitation of calcium and phosphate salts. Also, there is increase in the saturation when the colloidal proteins in the saliva, it binds to calcium phosphate ions. When there is stagnation, the colloids, they settle down, supersaturated state is not maintained and resulting in precipitation of calcium phosphate salts. Phosphatases, which are liberated from dental plaque, desquamated epithelial cells or bacteria, they precipitate the calcium phosphate by hydrolyzing organic phosphates in saliva, causing the availability of free phosphate, which is key for the calcium phosphate formation, causes the increase in the mineralization. Then the bacteria such as the cocci and the filamentous organisms, they releases the enzyme called the esterases. That esterase, it initiates the calcification by hydrolyzing the fatty esters into free fatty acids, which form soaps with calcium and magnesium, which is converted into calcium phosphate salts. Also, because of the epitactic concept, that is the seeding theory or the heterogeneous nucleation theory, it is said that small foci of calcification is first formed, then which enlarges. And this foci, it forms on the carbohydrate protein complexes where the calcification occurs from by removing the calcium from saliva, which act as a nuclei. Now, this nuclei will act as a agent for binding of the more mineral content and resulting in the increase in the content. So this was the theories, how the calculus is formed, how the calcium and phosphate contents they are increased. Now the dental calculus, it is not the primary agent or the etiological agent for the disease, that is the periodontitis or the gingivitis, but it is a contributing factor for the disease. Why? Now it acts as a nidus, it acts as a house for the plaque accumulation. On the calculus, the plaque is formed, and so this promotes the periodontal or the gingival diseases. A positive correlation exists between presence of calculus and presence of gingivitis. More the calculus, more will be the gingivitis. It is seen in young patients that periodontal conditions are more likely related to the plaque accumulation than calculus, but situation is reversed with the age. Incidence of calculus, gingivitis, periodontal disease, they are seen to be increased with the age. Rarely, periodontal pockets occurs in adults without the subgingival calculus. Subgingival calculus, it is very important for the pockets to develop. Non-mineralized plaque on the calculus surface is principal irritant. It is the irritant that causes the disease, whereas the calcified portion is just the contributing factor for the accumulation of the plaque. It does not irritate the gingiva also. That is calculus, it does not irritate the gingiva, but it provides a nidus for the accumulation of plaque and retain it to the gingiva. So this was the dental plaque, though is the main etiological factor, but dental calculus is very important for the accumulation of plaque, and that results in the periodontal diseases. So we have to remove the plaque as well as calculus while doing the SRP. Thank you.